Right. Join me in the Pledge of Allegiance.
Pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Thank you. Okay. First item, public comment. No public comment. So we'll go ahead. Second item is the consent agenda. Have you had a chance to read the board minutes? Any corrections?
Gerald has. Yes, I had one that's been correct, right, Jen?
Yep.
Okay. In other words, you were terminated. Okay.
I move we accept the consent agenda as amended with Gerald change.
Okay. All those in favor of approving the consent agenda as amended? Passes unanimously. Good evening, Ken. How are you doing?
Another long day, but I'm here.
Yes.
Good.
We'll put the storm washed in.
Yes, I did.
Okay. Item number 4. Go. The financial reports.
All right, so this is for September 2021. Okay, there we go. Patient count. Okay, so second line from the top, acute 22, 402, and acute, that's an increase of 66 over the previous year. For clinics 22, there was 1,851, it's a decrease of 204 over the previous year. Other outpatient services, 5,755, an increase of 696 over the previous year. Overall, for the month of September, they had 8,008 visits, an increase of 558 over the previous year. Also, too, just to point it out, the colors, the blue will always be 2022, the orange will be 2021, and gray will be 2020.
Okay. If you can get those to be the same colors for each chart?
Yes,
all the
I
way
did.
through? Okay.
Thanks to some insight from someone. I never missed that one, so. Gross patient charges for September was 4.27 million, an increase of 400,000 over the previous September. Let me see where we have it budgeted there for the budget. For collections, it was a record high of 3.517 million, which is above budget of 3.2. I think approved budget was going for, so we're making headway. It's not as fast as we like. Days cash on hand. For September, we had 85 days. It's 21 more days than this time in 2020, but we still want to get above the 90 mark. Monthly net income, for September, we had 4.27 million in gross revenue, less revenue deductions of 760,000. As you remember, in the previous months, they were much higher, so like I said, we're clearing through the stuff, you know. Less expenses of 3.1 million plus 98K in non-operating revenue expense resulted in a surplus of $417,000. All right, so the profit and loss statement for the month of September, and here I try to focus more on the year-to-date, year-to-budget. So through September year-to-date, total revenue is 9.2 million, less operating expenses of 9.8 million, plus or minus expense revenue of 346K. So you see, we're underspent on expenses. We're still a little under on revenue, that 658. It keeps seeing that 658, and that was our write-offs in those first 2 months. We're equal about that. I'm not making excuses, but we're almost there. Down below the net income year to date is 262. So that 417 got us almost there, but we still have more work to do. All right, net margin, I include this one again just so you can see how it looks year over year. For For September, we had a $543K increase in margin over the previous year, but still a deficit year-to-date of 262. 6-month trend. The past 6 months, we've averaged 3.3 million in revenue, which is above the budgeted amount of 3.2, while incurring 3.1 million in operating expenses, which resulted in an average surplus of 247.
Why does it show the net income of 402 instead of 417?
I took out the one-off. There was a one-off, and that's what, I wasn't able to reduce the expense by that much. All right, on the balance sheet, not a whole lot going on here. Cash saw a decrease of 340K, total assets of 55.9 million, total liabilities of 46.6, with a fund balance that was pretty much the same at 9.3. Next one is just a quick report on the HRG project. I don't want to get too deep down in the details like the big report I sent out, but just this is as of last week. They had 3,000 still in their inventory. They processed 517 out to insurance companies for a total of 2.2 million. The actual collections to date, as of right now, about 1.5 million, at a cost to the district of about 3 or 4% of almost about 35,000. So that's a really good return on investment for helping us get back up to speed again.
Any timeline on getting clear of the backlog?
Yeah, we talked about this today, and I think probably January, first couple weeks of January, I think will finally be clear, because they've actually, even though there's a 3,000 in their inventory and they processed 517 or so, it's like 48% of that total has gone out the door. So they're halfway there. They do have 6 full-time equivalents working on the project, and they're very best Medicare and Medicaid people. So, and they're working with our team pretty well. So I think, given the crew we have, we get fully staffed, we'll have them ready to go. I think they'll be fine. So,
Any timeline on getting fully staffed?
I would like to say within a month. I mean, we're cherry picking truthfully right now. Some of the other hospitals have some people that we're recruiting, but not a good thing. But they come in already knowing what to do, and you can hit the ground running. So
We're thinking very positive.
yes. And that's all I have for the hospital report.
Okay, thank you. And you're still up, you've got Goose Lake.
All right, so starting with Lakeview Gardens, revenue was 233 in September, expenses were 392, which resulted in a deficit of 158. Working harder to, you see the contract labor did go down, so we are paying closer attention to it. The next one is Lake Health Medical Supply. Revenue of 40K, expenses were 26, which resulted in a surplus of 14,873, and year-to-date of 34,048.
That's pulling a pretty good trend, that's positive, that's big improvement this year.
Well, do keep in mind that one of the things that we did is when we started off, we thought we were going in a good direction through our group purchasing organization at that time, Intelair. They offered us a consultant to come in and make suggestions. We were having some transition of management. What that consultant did is threw out just about everything that we had been doing and recommended changing everything. We changed billing companies, we changed lots of systems, lots of processes. The cost of that transition and the cost of the consultant was expensive, but you're seeing the results of the recommendations that this consultant gave us. So we have moved from having an active consulting role to a limited consulting role, to we're not having him other than on occasion we can call and for a very limited amount of assistance.
And a new facility.
And we're in a new facility.
We are in a new facility and we got through our inspections with flying colors. I mean, we did a lot of things. This is a very significantly different business than it was when we started.
Yeah.
And so you're seeing the results.
But the trend is continuing, which is good to see.
It is. Our biggest challenge right now, frankly, is getting a couple of insurance companies in California where a lot of our businesses is being called for to contract with us. And I'm just in the process of engaging another consultant to help us do that. And it'll be well worth it.
Okay. Continue there.
Oh, and that's all I have,
So
sir.
that's all you have? Okay, good.
Any questions?
No questions. Respiratory Services, Kim.
Hello, everybody.
Hi.
Hi. I wrote it down because I've never been to a board meeting before, so I'm just making sure I didn't miss anything. I'm Kim McFall. I'm the new cardiopulmonary services manager, and there's 5 different areas in cardiopulmonary services, and that's inpatient respiratory care, outpatient respiratory care, sleep lab, pulmonary rehab, and cardiac rehab. And just a little back history of myself. I've been in the hospital setting for about 20 years, with 15 of that as a registered respiratory therapist. I've spent most of my career at a 48-bed rural community hospital, and 7 of those years being the lone RT on night shift. So I've seen a lot. From the ER to med-surg, they had an ICU, and the busiest family birth center in the state of Oregon compared to population rate to births. So all I can say about that is babies, babies, babies.
How long have you been at Lakeview now?
I've been here since mid-September.
Okay.
Yep. So after 16 years at that community hospital, I was recruited to a large regional hospital where I added NICU to my plethora of experience and my skills. A little personal history, my husband and I bought property in Spring River, and so we're starting our homestead out there. So you can kind of say that rural living is what I do best, and community, small community hospital is my specialty, so I'm very happy to be here. By coming to Lake District Hospital, I hope to fill the gap between us being a critical access hospital and then also providing up-to-date relevant respiratory care to our patients. And that includes, of course, those with COVID or those suffering post-COVID effects. One of my goals has been to utilize the equipment that we do have, but at the same time, hopefully purchasing a few pieces of equipment to provide for and expedite healing for our patients of all ages, from neonatal, pediatric to adult. Mostly adult, of course, but being a critical access hospital, we need to be prepared for every little thing. Another goal I have for the cardiopulmonary department is to focus on community wellness. So I would like to put some more effort into marketing our cardiac and pulmonary rehab, as well as our accredited sleep lab. And especially with COVID, post-COVID patients, we just want to make sure that they're not alone out there, and we do have services that we can help them get through that difficult time. For our department, to fulfill staffing, we currently have 2 travelers filling in the positions, while we have job postings for 3 positions. Cardiac rehab, we are looking for a part-time cardiac nurse, and we're looking for 2 full-time RTs and a per diem RT. Our sleep lab and pulmonary rehab are staffed. I'm personally currently working on establishing quality assurance and quality improvement measures in all 5 areas, as well as reviewing our policies and procedures. Thank you. I've had a lot of mentoring. I'm also working with informatics and analytics to develop revenue reporting, as well as lost opportunities for growth of our respiratory staff coverage. My ultimate goal is to have RT available 24/7, 7 days a week. and to develop respiratory care protocols. But I know that will take some time, so I'm here to work on that. And I just appreciate this opportunity to be here. Do you guys have any questions?
Oh, thank you.
How busy is your department right now? Are you overwhelmed or is it?
No, we're not as busy as I think we should be. We're working on that. We're adding some procedures to our list, things that maybe have kind of fallen by the wayside that we can definitely do for our patients, and different modalities that we can offer. And we'll work with the physicians to make sure that that the patients are on track, because we all have the same goal, is to get them better so they can go home.
Kim, the sleep lab
Yes.
aspect, I understand that the procedure now is changing somewhat so people can do it in their home instead of having to come to the facility. Are we making that transition, or what changes might be happening there?
We offer that as an addition to our in-lab sleep study, which is the gold standard. A lot of folks they don't want to come and spend the night.
Mhm.
So we do offer an overnight oximetry study, and we have a couple of different devices. One's called a Nonin pulse oximetry, one's called a Nomad, and one is called a WatchPad. They all do about the same thing, but the reporting is a little bit different. And for the Nomad and the WatchPad, they do generate reports, and they go to Dr. Bauerfein for review, and so they all are reviewed by our sleep physician, and then back into the patient's chart and to the primary care physician. Yeah. So it is an option.
Thank you.
Sometimes insurances require that before the in-lab study,
Hmm.
but the in-lab study offers way more.
Yeah.
So,
It's more complete.
Staffing, how are you looking at, our prospects for getting to full employment, if you will?
Yeah, it is a challenge, because as you probably all already know, it's very hard to compete with the traveling pay and the traveling incentive. So I know many therapists who have left facilities because of travel pay. Not necessarily that they weren't making a good wage, it's just we just can't offer that type of wage with sign-on bonuses for travel. All of their expenses are paid. So that's the challenge, is to offer a full-time position to someone to move to a remote location.
Right.
And we can't pay $160 an hour. So, but I'm working with HR and working with Teresa, and we've got some ideas out there to try to at least put Lake District Hospital on the map, so that's planting the seed, because your life can change in a day, and your situation can change in a day. So maybe they wouldn't come here yesterday, but maybe tomorrow they might consider it. So my goal is to keep Lake District Hospital in the respiratory care career realm, so people see our name all the time.
Thank you.
Teresa, could you just give a little perspective for the board members on where we were 10 years ago? And that's a short time
in
period.
respiratory therapy?
Yes.
Well, Kim and I just had this conversation today. I really think respiratory therapy has sort of come into its own in the last 10 years. They have many more devices, many more modalities to offer our patients. And many of the patients that we intubated and put on ventilators 10 years ago, we now don't have to do that anymore, because we have other options that can be used in between and sort of save people from being on the ventilator. And that's been really true with the COVID patients. And so I think certainly
Staffing-wise.
10 years, pardon?
Staffing wise.
Staffing wise,
10 years ago.
10 years ago, we had 2 therapists, and we just had cardiopulmonary. So we just did just some in-house things and a few outpatient therapies. We've added a number of different outpatient therapies, even some in the last couple of years. And then, of course, we added the pulmonary rehab program and the sleep lab program. So I don't know if that's what you were looking at, thinking of, but
I wanted everyone to understand that it was even less than 10 years ago, 7, 8 years ago, we had 2 people. We now have 7, 8
If I had,
fully
full
staffed.
staff, it would be 8 to 10.
It's a significant change. It is because of what Teresa's been doing and what Kim is doing, and Kim, we've had some other people in that role, but it is taking off, and it really is a valuable service for us.
I assume you've given Charlie your list of equipment that you would like to have added?
Well, I go through Teresa first.
I think Charlie knows. We're just hoping for some more COVID money because we have some ideas.
Okay,
And I am respectful of the need. It's not just a wish list. It's these are the things that we really should have to keep our patients safe while they're here.
well, we're looking at the community service, and the more we can keep people here
Right.
without having to travel
Mhm.
hither and yon, it's better to be cured at home than
Right. Absolutely.
somewhere else.
Absolutely.
I think you touched on it earlier, pardon me if I missed, but the number of patients and our capacity level, the number of patients is below our capacity at this time. Is that correct? Is there actually numbers of people out there to fill that we haven't reached out to?
Well, in the outpatient world, certainly yes, and Charlie touched on that a little bit with the certain type of insurance that is not optimal for this. We're considered out of
Area.
area.
Some of the California insurances don't let us do outpatient services.
Haven't let us.
Yeah.
That will change.
Haven't let us,
Haven't let
okay.
And the other point to that is, I believe that it's with community education, provider education. There's a lot to our department, and I think we just need to have that constant seed planted of what the opportunities are out there for their patients, especially with our rehab, cardiac and pulmonary rehab, and the sleep lab. Those 3 areas should be very busy, especially with COVID, post-COVID patients.
Now, most of the patients would go through their primary physician before they come to you, so there's good
Or a
communication.
pulmonologist.
So there's good communication there for physicians to recommend.
We're working on that.
Thanks.
Thank you.
The only other thing I would like to add is that having a pulmonologist come to our facility would be exponential, I believe, in our referrals. We don't actually have, like with cardiac rehab, we have Dr. Quaria that is available for patients. I think every 6 weeks he comes to the facility.
Where is he based out of?
He is based out of Bend, I believe. Yeah, St.
He's a
Charles Medical Center.
cardiologist.
He's a cardiologist. So the downside of not having a pulmonologist, there's many, but I think that with COVID, it also opened opportunity for remote care. So one of the things we might consider is having a space once a month for a remote appointment. I know I personally have had doctor's appointments by phone and by video, and so I think one thing COVID did was open up the possibility for operating that way. Winter and things like that for whatever reason, but I think having a pulmonologist would be very, very important.
So to address that, we've tried to get a pulmonologist here for many years. And we worked really hard with the St. Charles group because that's where a lot of our pretty sick patients are going. Bend has struggled to have a consistent pulmonology group there. They are now able to have a group and they're looking at expanding. We are talking with them. One of the reasons why our sleep lab medical director actually comes from Providence in Portland out of the Oregon clinic. because St. Charles couldn't handle it. Now, he happens to be a fabulous physician, and he came through a relationship with Providence that we have through Infant. But she's absolutely right, that if we could get a pulmonologist here, that would be a great addition to the specialty care we deliver. And we're trying to get them. That's the nature of some of them.
Would that be a full-time or a traveling part-time?
It would unquestionably be just a physician here for a day, like the cardiologist that comes once a 6 weeks or once a month. We could get to that. Because oftentimes, these specialists need to have very sophisticated equipment that we don't have. And their time is spent with very sick patients. So coming here for a day is pulling them from that category of patients that they have to deal with that are truly very, very sick. Most of the time they're working in ICUs. So, but they also know that this is an important part of the care that they're delivering to the wider area of the community they serve.
Okay, anything else?
Thank you for the update, Kim.
Yes, thank you very much.
You're welcome, thank you.
Sounds good, okay. Item number 7, the CEO contract. We had not come into an open session to approve the contract after we discussed it at the last board meeting. So I would like to hear a motion to approve the contract as we have, and Charlie has it here if you need to take a look, but it's the contract we discussed last board meeting.
Why so we accept the contract?
Okay,
Second, your contract.
been moved and seconded to approve the CEO contract. All those in favor? Aye. Passes unanimously. Okay.
I get to stay.
Yeah.
Another 5 years.
Yeah, you're in trouble now.
It's happened before.
Okay, the EMS equipment, and that's with Tyson. And
I'd like to,
you want to start?
before Tyson talks a little bit about.
Okay,
I'd like to talk a little bit and remind everyone of how we are working with our EMS service. So we took over September 1st, 2020, so a little over a year and a couple of months from the disaster unit. They had that agreement until August 31st. As part of our agreement with the disaster unit, we signed a contract to lease their equipment for $1 a year. And then at the end of that term, we would have the option of extending the agreement for another year, purchasing the equipment at fair market value, or saying thank you very much and we would go and buy it. Those were our options. Last summer, we talked about how it would make sense to buy the equipment and that we would proceed with transitioning the equipment. Some of it is aged, and that we need to replace some of the equipment and start in buying newer equipment so that we have a good inventory of equipment that we can always trust. Remember, we talked about how Tyson had a great suggestion and an arrangement with the company. The box that the patients get transported in is in great shape, but the vehicle is the drivetrain and the engine are getting older. Well, there are companies that will take the box off the back, put it on a new frame and a new engine, and you essentially have a new vehicle. The box is still in great shape. Takes about a year, if I recall.
A refurb and remount probably takes 6 to 9 months.
6 to 9 months, so not quite a year. But it's a really cost-effective option. And so that was one of the things we had planned on doing. After reflection, we felt that it would be better, given this year in our financial situation, to postpone buying all the equipment and So we would like to continue our lease agreement for $1 a year, continue, and then reevaluate this at the end of this year. Received a letter dated October 19th, well, we got it on October 19th from the disaster unit that says they would rather not continue with the $1 lease. They would like us to buy all of their equipment for $300,000 with payment of $20,000 for 15 years. That doesn't quite match with what our plan, what our agreement is, which is fair market value. And I think they were looking to give us a way of managing our cash in a different way. But I don't think that it is in our best interest to enter into an agreement like that. Tyson and I have talked about other kinds of equipment arrangements, and maybe you could talk a little bit about that.
Yeah, the big thing with that $300,000 offer that they're trying to get us is they have, I think, three ambulances sitting, one outside the fire station downtown, one out in Adel, and one out in Plush that are not able to be licensed. So the one, we actually amended the agreement last April, I believe, and took it off of the lease agreement because it's not able to be licensed as an ambulance.
Okay.
Their plan was to sell us those 3 ambulances as well, and just have us turn around and sell them to recoup some of the cost of the agreement. 2 of those, I believe, are federal excess property, so you have to go back through the federal government to return them. Return, they end up sending you the title 99% of the time, and then you can sell them off. But I have a hard time spending that amount of money to buy 3 unlicensable ambulances that are just gonna sit, or we're gonna flip around and sell. It just doesn't make a whole lot of sense to me.
Why wouldn't they just sell them on the market?
I've asked them that. Well, why don't you just sell them? Is the response I get.
But if we can't license them, neither can other ambulance.
No, they're scrapped, basically.
But they,
Well, keep in mind, when we say scrap, we can't put them on the highway hauling a patient. They do go off-road. And so if someone is in an accident 5 miles from the road, these vehicles are used to bring them to the road where they're transported into a real ambulance and then taken to where they need to go, either an airport or to the hospital.
Well, basically, what's the fair market value of the equipment? You know,
On even the two big boxes, the 2 internationals that I wanted to remount, those things are only worth about $25,000 a piece.
and these are ones that we are
Currently leasing.
currently using in our fleet right now.
Yes, the 3 that we're currently using in our fleet right now, the newest one that we use for all transfers is worth about somewhere between $100,000 and $125,000. And the other 2 are only worth about $20,000 to $25,000 a piece.
Did we buy one?
We have a brand new
We have
vehicle.
Yeah, we have a 20.
But is that the $125,000?
No.
No, okay, so
So we have 2, between the lease and the one that we own, that is the health district, we have 2 ambulances that are built within the last 5 years.
Okay.
Those 2 are in really good shape. So,
are 2 adequate for our area?
I would like to see 3, that way we can keep one out in, Adel. Cause those guys out there, they're pretty good about staffing an ambulance for us when there's a run out there, and then it usually ends up being me just going out in the Tahoe if they need a paramedic.
Okay.
3 to 4 ideally is probably exactly what we need. I know there's some folks from the disaster unit that would probably argue that with me. But I think adequately 4 ambulances would be able to cover this area pretty well.
You'll have to arm wrestle Kim for the money.
But it doesn't make any sense to spend $300,000 on fair market value of 125 plus 50,
Yeah,
175,000, so.
Yeah.
we
And when,
had to,
when we approached them with the offer in August or first part of September, we offered them, I want to say it was around $210 or $215, but that included the extrication equipment, the gurneys, the cardiac monitors, and all that that's on those ambulances right now. The extrication equipment that's on the 2 ambulances here in town is obsolete. But we just got a grant to replace it.
Have we gone back to the disaster unit and said, let's get a third party, do a third party appraisal of the things that we can use?
That's what I did when I gave them the
And
offer.
they said no?
They said no. They think they're gonna wait, the last I heard was they're gonna wait till January and try to find somebody else to do an appraisal for us, because they don't trust my numbers.
Well, no, but the numbers we got weren't from us, they were from a third
They
party.
were from a third party, and I tried to communicate that to them. It was from Brindley Mountain Fire Apparatus.
And after all, we do want to find a reasonable solution.
Yeah.
So, my reason for bringing this to you is so that you understand that we have received this. It's a little bit different from what we were anticipating, but we want you to understand where we're at. We still want to continue to find a fair solution. And we picked a third party. If you want to pick another third party and have a different opinion, that's certainly possible. But in this fiscal year, we have a lot of equipment needs and a lot of capital needs. We want to be thoughtful about how we do it.
But this also fits into the long-term scenario of replacing our ambulances every few years.
Correct.
And we want to get on a regular cycle
Yes.
so that we don't run into a problem like this in the future.
Right.
We're getting our feet wet.
But it's important for you to understand the issues as they're coming.
Thank you.
So it's just mostly an informational situation.
Okay. Any other questions?
No.
Thank you, Tyson. Appreciate it.
you.
You're missing the football game, you know.
Oh, I know.
Okay.
Who's playing?
Colts and the,
Yes. Colts and the Jets, yeah.
I'll speak faster. So in lieu of the, Dr. Foster was not able to be here tonight. I thought he was going to be able, but he couldn't. We had, the medical staff met and it had 3 applications. I think you all have seen them. One is Dr. Younger, who is our consultant pathologist. One is Dwight Smith, who is a physician that works in courtesy staff covering our emergency room. He's a family practice physician. And then we have a consulting radiologist, Dr. Benjamin English. The medical staff recommends that you approve these applications.
So moved. Then move to approve the applications, medical privileging as presented.
Second.
Moved and seconded. All those in favor?
Aye.
Passes unanimously. Good.
Thank you.
So nursing report, Teresa, you're up.
I am. So in lieu of complaining about not enough nurses, I thought we would do something different. I can do that though if you want.
You can do it. I don't know what to do.
Great to see the new graduates in the paper the other day.
Wasn't that great?
Yes.
Yeah,
Was there 6 of them?
there was 5, I think. Maybe there was, I'm having a blank. But anyway, they're pretty much all up and running, and we're reaping the benefits of that class. So Terry does plan another class in January, so we look to try to do that again.
Way to go.
Applicants cooperating, of course, that helps. So speaking of Terry, I wanted to talk to you a little bit about our clinical education. So Terry Carlin took the position for clinical educator. That meant we lost her off the floor, but the good news is she really likes the job and she's doing a great job.
Good.
So she's worked now with Klamath Community College on the CNA 1 class. She just finished the CNA 2 class. So I think that's what was in the papers. That may have been 6 people. I was thinking of the other class. She also has 2 students from the Klamath Community College that she works with on the floor. And so she's there the whole time that they're there as their clinical preceptor. And we're looking forward in January to having 2 students come over from the OIT program for OHSU. So they'll be doing their last term with us. Used to be called reflective practice. I think it's called capstone now. It's their final term. She also is working hard on kind of bringing together our quarterly skills days for nurses, as well as the plan for the rural nurse residency, which we'll be also offering in January.
What is that?
Pardon?
What is that?
So that's what we call our introduction education for new nurses that come to Lake District Hospital. So even experienced nurses don't generally have all of the breadth of knowledge that they need to work at Lake District Hospital, because typically you work in one area and not all the areas at once. So we always put people through what we call rural nurse residency, and it works great for new grads. So it's between 2 and 3 months of classroom experience. Every week they do a full day of classroom experience with a variety of topics and instructors. So it's really, it's a great thing. It goes along with their clinical work at the bedside. So they do both classroom and clinical work, just to kind of learn our ways. We've also had a health educator for the last 2 years at least, maybe 3. And that was Courtney Dory, and she's been teaching CPR. So if you've taken CPR here, you might have taken it from her or one of the other CPR instructors that she coordinates. So we also offer youth CPR. We were offering the Safe Sitter program, but that got shut down by COVID. So all of those things are part of the education that we offer. Courtney has decided to pursue a different opportunity and work from home. So we're kind of looking at revamping our education and who's going to offer what. Because at the same time, all of these things are acute, and there's also a need in long-term care for education. They're required to provide a certain amount of education every month. So it's a lot, but it's going well. I think we're doing a great job, but we have maybe some potential for other opportunities to do to approach it differently and maybe offer more. So that's kind of.
If I could just add something on the education part, putting it into perspective. Oregon Tech also has a radiology program for radiology technologists. And for the first time, we now have a student from that school here who has started and will spend, I believe it's 11 months in their clinical rotation here. First time ever. So one of the things that we're seeing as we've expanded our relationship with Klamath Community College, it has brought us into many more opportunities for educational purposes. We actually have 2 people, I think it's 2, certainly 1, who's in the Klamath Community College electrical or electrician program as part of their training to become a licensed electrician. We have more and more opportunities where our workforce is getting more and more education. So as we look to expand the services that we do, it's not just nursing education. A lot of times we think just RNs with this education. There's a whole lot of people that are involved in this education. And community. As Teresa said, our CPR, we have a responsibility to make sure that all of our employees have CPR training. We also provide CPR training to firefighters and to all sorts of other organizations. So that's part of this whole education service. It's a good thing.
Questions?
How busy has the hospital been lately?
Up until today, this very day, we've been very busy.
Today was a slow day.
Today, we discharged some patients and our census is a little lower today. And as of this afternoon, our isolation rooms are empty. And, it could have changed in the last hour, but that's how it was when I left.
Okay, thank you, Teresa.
Good. Thank you. Any other questions? Okay, thank you, Teresa. Okay, we're up to the CEO report.
Before I start,
Oh, wait a minute, yeah. Go ahead. You had one other thing you wanted to add, didn't you?
we'll talk a little bit about food share and a couple things
That was
in a
it.
moment. But I was going to see if Rebecca had anything she'd like to report.
Oh, yeah, thank you. So, with all of the angst over the vaccination mandate, we ended up only losing one employee out of all of our employees to the mandate. They did not want to have the vaccine and they did not want to complete an exception form. They had the option of completing a medical or religious exception form. And they chose not to do that, so,
When you say they, you mean the one.
I'm sorry, say that again?
You said they, but you said one.
One person, yeah, they chose not to do the forms or the vaccine, so that was quite, wonderful to just lose one employee overall. That we hate to lose that one, but at the same time, we also have to respect their right to choose.
Right.
So, I just wanted to give you an update on that, so everybody else was intact.
That's about, 402 people, including contractors and volunteers.
Yep, give or take 5 or 10, and yes, so.
Okay.
That's all I wanted to report.
Thank you.
Thank you.
Okay, now we go to the CEO.
So a couple things. One, I would like us to talk a little bit about food share. We've been talking about that. Our vendor, Singh, was on our agenda to talk tonight, but he was unfortunately ill today. So we couldn't, we've made a lot of improvements to the building, and that was something that was brought to our attention by Gerald and others. And I think we've accomplished most of them. We have not been able to pave the front or redo the sidewalks as that was requested. But we've done a fair amount of other things. We have now built a walk-in freezer and a walk-in cooler. We have the capability of handling quite a bit of frozen, and we are making meals for the backpack program
For the school district.
for the school district.
We get food for kids.
And I think we're helping assemble 150,
Last week we did 169
169
bags.
bags of lunches for children that they take home on a weekend so that they have meals over the weekend. So that's a fabulous thing. It's extraordinary.
Yeah, Food Share's been working with the high school together, so, and then also the hospital. So it's really the school district, the hospital, and the Food Share group working together on this.
It's taken a lot of people to do this, but it certainly is in line with what our studies have shown when we look at the needs of the population. And if you recall, we've had several VISTA students. It's through a program kind of like Americorps, where we sponsor and we put in some money and they come here and help us with issues. They've been involved in the Oregon Food Bank and doing food insecurity studies and throughout Lake County, and then teaching kids in different years, teaching kids about different kinds of foods that they can eat.
Susanna from Americorps is involved in this program.
She is too, yes. So this has been a continuation of dealing with food insecurity. That's what we call dealing with people that have hunger, call it
Of
hunger.
course, Rotary's little pantry is
Another
another
perfect example.
key part of that charter.
There are a lot of things that are being done in our community to help deal with the food insecurity that so many people suffer. So it's exciting that we're a part of that. And I was hoping our vendor could talk a little bit about that. One of the things that we're responsible to do every 3 years, we have to update a needs assessment for our community. And then what are we doing as a health district to not only identify those needs, but then what are we doing to actually put resources toward addressing them? Food insecurity is one of those, housing is one of those. There are a variety of different items that are found on our website, and we work to update them. And the requirements to do this, it's not just because we want to, it's because we have to, we do both. We want to make sure that we're staying on top. So when our vendor is feeling a little better, you can come and talk about the needs assessment and where we stand on that. I was going to talk a little bit about the mandate, but thank you, Rebecca, helping on that. What we ended up with is 61% of our workforce has been vaccinated, and the 39% have signed exemptions. It's very typical of other remote parts of and rural parts of Oregon in terms of percentage of vaccinated versus unvaccinated. Many of the communities, many of the bigger hospitals have chosen to accept people's exemptions, but have not allowed them to work in patient care areas. Our position has been, my position has been, that every place in this hospital, in this health district, involves, every position involves dealing with patients, and that we can't possibly require that everyone be vaccinated or exempt people that have exemptions for medical or religious purposes not be able to continue caring for patients. Our responsibility, my responsibility, is to ensure that we keep our employees safe and that we keep our public safe. So we do all that we can to require people to wear masks, do social distancing, thank you very much, and wash their hands as frequently as possible. So I think we're doing okay. Some other communities have struggled more than we have. So we'll continue to work on it. One of the things that I would like to ask your opinion on is we have received a significant amount of money in the last year and a half since COVID started. Some of it has come in the form of the PPP loan. Some of it has come in the form of grants from either the federal government, the state, or from various organizations. And then we've also gotten direct money from the federal government as part of our Medicare. They gave us advances to ensure we had enough capital. As you recall, we put most of that money into a special pool until it was deemed to be a grant, and then we could use that. A lot of the money was used to make up for the lost income that we experienced when COVID caused us to shut down a lot of our services. Since that first tranche of money, first and second and third tranches, because it came in different ways, has come through, we're now receiving some monies, and it's substantial. We've received, I think I reported about $700,000 or $800,000 in both public health and in our rural health clinics, special allocated monies. We have to spend that for very specific purposes. One is COVID vaccinations, and two is COVID mitigation. Some of the grants have to be spent within a limited time period. Some of them we have a little bit longer time period. There are restrictions on what we can do, what we can't do. What I need to know from you is if we need to have board approval before we move ahead with those purchases. Now, last board meeting, I brought to you, we had received monies and there's an opportunity to buy eugenics testing equipment for COVID. And we bought two, one for each of our rural health clinics. They're $27,000, so they're not cheap. We bought two. Because of the monies we got for our public health, it makes sense to buy another one for our public health department. Now we have principally two locations, one here in Lakeview, we also have one in Christmas Valley. We decided not to buy one for Christmas Valley because of location. We don't have enough space, and there may be some challenges with running it on a consistent basis. We still can do that, but I authorized the purchase of that $27,000 with that grant funds. If you would like us to present all of those purchases before we make them, then I need to plan that in advance and get that to you. If you want us to treat this as a grant and that we do the best that we can to use those monies carefully and then report what we've done, that would make it a little easier on our part. But I don't want you to think we're spending money willy-nilly
I would like to know.
in advance.
And if you wanted to put some type of a dollar amount on that, I would be okay with that too. Amount not to exceed.
So there are a couple things that we will then try to get to you as quickly as we can. We received a grant to do some work with the youth, and we're a couple $100,000 on some dealing with, I think I presented this to you in the past on our grant programs to deal with suicide prevention among youth. And so we're buying equipment to do videoing and podcasting. And so along with that goes a trailer and a bunch of things. In order to pull that trailer around, we need to get a vehicle. And so we have COVID dollars to be able to spend on. We will bring to you all those purchases.
I get what Gerald said, I mean, I think we should set a threshold, we don't need to be involved in every.
The eugenics purchase is $27,000. Do you feel that you'd like to hear about expenses over $50,000, under $20,000, over $20,000? What do you feel is
20?
The Gen X, could we buy one in advance for Christmas Valley, even though we don't have a place up there? But in anticipation of having a location installed in the next.
So, good question, because one of the things that we, for example, in these grants, you have some of the money we have to spend before the end of this year.
Right.
This calendar year. So we have less than 60 days to make these purchases. What we'd like to be able to do, as an example, is for the Gen X equipment, buy the supplies. But we don't have space to store the supplies, and they don't necessarily last for a year. So we're trying to see if we can if we prepay the vendor, and then have them send us an allotment every month, where they hold on to it, and then they allocate it at different times. I don't know if we can make, there are restrictions on these monies. And if we don't spend it, we have to give it back.
Right.
So we want to be thoughtful, but we also don't want to squander any of that money. I think that's wrong. So we look very carefully for items that we could buy that would support the intent, encourage people to get vaccinated, or help people understand, the public understand how to mitigate the spread of COVID and do it in a thoughtful and proper fashion. But when we buy these equipment, we want it to be able to be used, because COVID's not going to go away. It's going to go, I think, from a pandemic to endemic. It's going to keep reoccurring. So how do we think proactively for the future that we don't make changes that we wish we had done one thing and we did another? But 20,000 is what you think is a threshold would be reasonable. And that's for capital equipment, not. I mean, we get a lot of small items. We'll report to you some of the smaller items that may add up to $25,000. Does that make sense?
Yep.
We certainly have to abide by all the grant monies.
Sure.
And all the reporting on that. So I don't want you to think that we're not paying attention to it, but these are not budgeted items. But we got specific money and we want to use it to benefit our community. We've talked about, for example, some of the equipment that we could use on the ambulances. the lifts that we've talked about, they're running about
They're,
$20,000?
yeah, about 20 or 23,000 a piece.
Okay. So we could conceivably use some of that. And so you'd say, well, how does COVID impact that? Well, if we limit the number of people that are going on a call, and a mechanized lift makes it so that we have two EMTs or paramedics working with the patient, not 5, because it's a heavy lift. That's a safer way of taking care of patients, and it's safer for our employees. And for the patient, we certainly don't want to be in a position of lifting somebody halfway and dropping them. That doesn't do anybody any good. So there's rational reasons we would do it, and there are other opportunities, whether we have things that Kim has identified or that other departments have identified, and they truly do benefit not only COVID patients, but the general public.
I still think 30, because most of the things I've just heard, things are 20, 25. So if it gives some leeway, having around 20, it cuts off most of those things.
I like 20.
I like 30.
What do you like?
20.
25.
25. We're going 20.
$20,000, thank you very much.
So 20.
We will still report to you the things that we're doing. So it's not like we're not gonna do that, but
I think this is just guidance for him anyway.
right. That's exactly right, and thank you for that. So then, if that's the case, then I did not put this on the agenda. We have a eugenics purchase for $27,000 for public health using COVID grant monies. I would like to have approval to make that purchase.
So move.
Second.
Been moved and seconded to approve $27,000 for the equipment. All those in favor?
Aye.
Passes unanimously.
Thank you. I would have put that on the agenda as an item to, with the yellow marking to ensure that we approve that. I apologize for not doing that. Moving on, Dr. Foster has announced that he will be moving to the coast, but we struggle with some specific dates. He has now confirmed that he'll be here full-time November and December. January, he'll move to 2 weeks here, and then starting in February, we're still not sure. He's asking if he might be able to work 1 week here and 3 weeks on the coast. I'm not sure what that means, but it's important for the public to know, as well as the other practitioners that work with him, that we have commitments at certain specific times. So I wanted you to know about that. There is never a shortage of things going on, and whether it's in the hospital or it's in any one of our clinics, we had a walk-in surprise survey for our assisted living last week, and so we went through that. And we'll get the results of that survey in Tuesday about 2 o'clock in the afternoon. This week, the surveyors arrived in long-term care for their annual licensing survey. They'll be here, there's 3 of them. They'll be here until Saturday. This is a learning experience for some of their staff, so we get to be the guinea pigs. Poor Rob has been quite frantic because it's a lot of jumping around. And when our license issue came up for long-term care and paying our fees, they said, well, we'll put it on hold because, after all, the fire marshal has not come to any of the long-term care facilities or the hospitals in the last couple of years because of COVID. Well, fire marshal showed up on Wednesday. So we were approved. They will get the final results, but they came and finished them. They'll have 1 or 2 things that we have to do. So it's been kind of a hairy week, and it still is a hairy week for her. With the COVID dollars, one of the things that we can do is we can't necessarily build a brand new building, but we can use it to make modifications. One of the things that our team has identified is the entrance to our COVID clinic, the C clinic that you see out front, is really not as convenient as we'd like. So we've approached our architects about remodeling the main clinic. And those of you that remember where the old specialty clinic entrance is or was, that was made into a storeroom. We're gonna reopen that entrance and make that right off the front, so if someone comes to the clinic and is symptomatic, we'll be able to walk them right around the corner. So the architect is finishing the drawings, and we'll be putting that out to, either put it out to bid or we'll do it ourselves. So that's in process. We have a change in our mental health leadership. Heidi Martinez is now our interim executive director. We are looking at several candidates, and he's doing a great job. And so we'll be looking to interview and make a final selection in the next month or so. Don, you had asked a question about what is the percentage of flights that air ambulance companies come here? 80% of our air flights are airlink. 8% is Mercy, 8% Life Flight, and 4% are other. There's a question about a company called AMCN.
That's their life, isn't it?
I'm not sure.
I think it is.
Okay, so 80% of our flights are with airlines. Just want to make sure anybody, in case anybody had any questions.
Where are they based out of?
Airlink is based out of Bend with a
Or satellite station.
satellite in Klamath, yeah.
So most of the planes coming out of Klamath, or are they?
No, the fixed wing's all come out of Bend. The
Helicopters.
helicopter, occasionally we'll get a helicopter from Plymouth over, but most flights go out fixed wing and they come from Bend.
Any questions I can answer for anyone? Things that have been going on.
I think Air Life is AMCN.
Oh.
I got some cards.
Pick a card.
Pick a card. I got Mercy in here, I got Air Life.
There's never a dull day here, I can tell you. Okay, any other questions or anything I can address? Ken, you had a question?
I was just curious about this, what you sent out, if you have any suggestions on that.
It's hard for me to see, I'm sorry.
It's the American Hospital Association Conference.
Oh, yeah. Thank you for bringing that up.
February?
So February in Phoenix. The American Hospital Association puts on a couple of conferences throughout the year. They have some in the Washington DC area so people can go meet with legislators. That's really been put on hold for the last couple of years because of COVID. The conference in Phoenix is for specifically rural issues, rural hospitals. Some are critical access. Klamath, remember, is considered a rural hospital, Skylights. So there are a variety of different sizes and locations. It's an excellent conference. In the past, Jane O'Keefe went one time. I've gone a couple times. If they do have a lot of information for board members, so should any of you want to go, many of you have, in the past, board members have either been too busy or too something. But if that's something that you're interested in doing, the early bird registration is December 3rd. So I have a brochure in my office and I'd be happy to. But there's also links on that I sent out to you. So it has information. And if anybody would like to go, great. That's why, I try to send you as much information as I can. One of the keynote speakers is Jamie Orlikoff. And I don't, Gerald and Don, I think you were on that board. He is actually chairman of the board of St. Charles Health System. And so lives in Chicago and is on the board. He's the chairman of the board now. And he put on a special board training in Burns a couple of years ago. He's a noted expert on board management, board role, board, a whole lot of thinking. And of course, as hospitals throughout the country, especially rural, are dealing with not only COVID, but what are we gonna look like in the future? There's a lot of time, there's information that helps board members understand not only your role, but how to help in shaping our future.
With that subject, I think it'd be good for any of us to go. But do you foresee anything on the future that'd be more closer and less costly to cover the same topics?
You know, every time that someone says we're gonna have a conference, it goes to virtual. We have lots of virtual conferences. Zoom fatigue is not an unrealistic thing to have.
It is the path of the future.
There are lots of Zoom opportunities. Many people have chosen to use that as a method for education. That's always available. There's lots of it.
Like special districts has different things offered as well. Some fit, some don't.
The hard part about special districts for the state of Oregon is there are a lot of non-healthcare special districts. So you kind of get stuck with the ports and the cemetery districts and the other important, but not necessarily healthcare. So you want to look for something that makes use of people's time. I'm not promoting this, I'm just saying, if this is something that you'd like to do, please let us know if you'd like to do. That's why I said that. Anything else?
Okay. Hearing nothing else, executive session, Charlie? Yes. So we'll adjourn to an executive session under ORS 192-660, bracketed 2, bracketed A, personnel, bracketed C, medical staff, bracketed E, real estate, and bracketed H, legal. And we'll take a 7-minute break.